age range, we are getting uh, new onset diabetes more and more. And so there is a recent trend of decreasing age of onset of diabetes. So gradually we are having diabetes, the onset in younger age, even below 40. And then there is a rise in above 30 due to lifestyle factors and other factors now influences. So usually from the Western counterpart, we have a decade earlier onset of diabetes. And also, I think at your practice, at what percent of cardiac patient do you get diabetes?
Agreed. Totally agreed that when we were students, we used to see that patients around 45, 50 comes being diagnosed with type 2 diabetes. But of late, they are even in their late 20s, early 20s, and they are not type 1 diabetes. They are type 2 diabetes because of the lifestyle modifications, as you said, the lifestyle we lead that they come very early as in the 20s and 30s with type 2 diabetes. And I obesity is one of the most important reason that we have now childhood obesity increasing in numbers, and those precipitate and they become frank diabetes and third. As I said that in our practice in cardiology, once we see acute coronary syndrome presentation, 11% of the patient of acute coronary, 11 to 12% patients with acute coronary syndrome did not know that they were diabetic, and they were diagnosed diabetic as they presented with ACS. So that's quite a dismal situation, that around 10 plus percentage of population who comes with ACS at their early age, they don't know that they were diabetic, and only once they are investigated along with the other investigations that they are found to have diabetes. So that is the dismal situation what we are facing in cardiology, and these are the numbers as according to me are the reasons. So what do you feel that diabetes and obesity are they like hand in glove with each other, or like is it still a long way to go, or there are some common factors as far as obesity and diabetes is concerned? Dr. Subir?
Yeah, actually,
sorry, Dr. Kadu.
Sorry,
Dr.
usually
Subir,
diabetes
yeah.
and obesity have common soil. Actually, the insulin resistance, obesity, these are run side by side. And usually in our practice, we found around 30% patients have obesity. If we see the BMI criteria for Asian, 23 more than 23 kg per square meter, so around 30% have obesity. And if we consider the central obesity, so it will go more. Around 40% patient we get central obesity, and we Indians have thin limbs and with central heaviness. So that is the common phenotype we usually found. And I want to ask another thing, that in ACS patient, how many of patient you get those who are non-smoker?
Right. So they were non-smoker is a less number, and they get ACS once the age is above 50. But most of around 60% to 70% of patient who comes with the ACS at a younger age are 70% of them are, or most of them are, that is the commonest reason for ACS at a lower younger age. But as I said, that 11% of patient diabetic, which they did not know. And obesity is one risk factor. We found around 50% of the patient, they are obese. And I think that they could be the metabolic syndrome or syndrome X that they were suffering from, that if you see their cholesterol levels, they are high triglycerides, they are hypertensive, low HDL, and as you said, central obese or obesity, definite obesity, and the high and smoker, that they start macrovascular complications well before. And the patients which are around 70% in our clinical practice, and of the smokers, most of them smoke and at an early age, and that is why they come with ACS at early age. So these are the percentage which I nearly see in practice about smoking and the diabetes, the relationship. So what are the best measurement methods for controlling the blood sugars, like continuous glucose monitoring or HbA1c? Or HbA1c is required for diagnosis, and how do you go about it? The continuous glucose monitoring or HbA1c, which is preferred, or like each of them has their own pros and cons? How do you diagnose diabetes? How do you
Definitely,
manage?
HbA1c and continuous glucose monitoring two are now important parameters. So previously, HbA1c was only used to assess the monitoring of diabetes, but nowadays this CGM is available, but it is not available in everyone, and we are not doing in every patient. This affordability issue is there, but in selected patient, so we can use it. Definitely, CGM and HbA1c gives an average of 3 months glucose, but the CGM with same HbA1c value, there may be variations in blood glucose levels. So with only HbA1c, a patient may have achieved 7% of HbA1c, but there may be lots of hypoglycemia and hyperglycemia incidents may be there. But with CGM, we can detect how much time they are spending in time in range, or how much time they are time above range or time below range. So ideally, CGM should be done, but it is not possible all the time. So especially in brittle diabetes or patient, those are receiving multiple subcutaneous doses of insulin basal bolus regimen. In that case, it is very much advisable to adjust their lifestyle, diet, and along with the medication. So, and also identify the hypoglycemia and hyperglycemia incidence also. So as a whole, if we, the glycemic variability, if we consider, it can only be detected by CGM, not by HbA1c. So our target of treatment is now shifting. It is control of blood glucose, keeping the blood sugar in range, avoiding hypoglycemia, avoiding weight gain, and now with additional benefits of extra glycemic benefit like metabolic, cardiac, and renal protection benefit is our now target. So usually we target glycemic value, time in range value should be between around 70%. So normally we time in range called like blood glucose between 70 to 180. So this should be kept around 70% of time. So this will give around HbA1c of 7%. And HbA1c have also, it is a very good tool for monitoring of glycemic status over the past 3 months. But there may be a lot of fallacy regarding the number one, it is whether it is a good laboratory or not. Many laboratory gives a result that is not reliable, and also in thalassemia and other like condition, there may be some variability, or HbA1c may not be reliable. So we have to think it cautiously. So with HbA1c, and if we adjust, if we consider the blood glucose monitoring with glucometer, that is also acceptable in our country. If we monitor 5 point or 7 point capillary blood glucose, that is also a valuable tool to assess the glycemic status.
So for the benefits of listeners, what I could gather is preferably the continuous glucose monitoring is preferred, because that would tell us that how percentage of time in range the patient is, and we want 70% of the patient should be in time in range of the sugar, and they should not have too many hypos and hyper incidences of hyperglycemias. But practically it is not possible, and HbA1c along with checking of blood sugar from time to time with a glucometer is an important tool. And I agree with you that and if you agree that most of the trials they say that they don't consider the glucose labels. They consider that what should be the HbA1c target where we can get the benefits of the any medication, any trials if done like with any active ingredient, that we always talk that the percentage of HbA1c the patient is in, and that tells us that the benefits of the medications. And of course HbA1c as a long term is a good important marker that how your sugars are well controlled or not. But as that CGM is not possible. I think it's a costly affair also. CGM is
Costly.
slightly a costly. Yeah. So that's important. So,
Yes.
yeah.
I want to know from you that how you suspect cardiac disease in a asymptomatic diabetes patient, and clinical or any other investigation you prefer to.
Very important, very important and interesting question, that a patient who is otherwise asymptomatic, how do we suspect? So once you diagnose diabetes, the first tool, ECG is the indication now. So you should have a baseline ECG with the patients. And if you could see on ECG, and most of the diabetic patient, around 60-70% of they have other comorbidities like hypertension, and the patient would be obese or a smoker, that if there are some subtle changes on the ECG, like left ventricular hypertrophy or like a left atrial enlargement, if you could see on the ECG, then we know that these patients are a high probability of going into heart failure in their future and may get atherosclerotic cardiovascular diseases. So we suggest an echocardiogram, and once echocardiogram also shows that there is a left ventricular hypertrophy, and echocardiogram there is a left atrial enlargement, there is a volume increased volume index E by E prime, which is a marker on echocardiography of diastolic dysfunctions. Those are there, and if the patient has a strong family history of heart disease or has other comorbidities like hypertension, smoker, then we like to take them for a provocable testing, like initially preferably a TMT or a stress myocardium thallium scan we do. Now, if those are negative, then one can nearly rest assured that the patient doesn't have too much of cardiac involvement. Patients who are at a high risk and who had more risk factors, very simple tool now, a coronary calcium score can be done. That's very important, because now we say that all patients who are diabetic above the age of 50, irrespective of their cholesterol level, they should be on statin. So coronary calcium score is one test which tells you that this patient is eligible to receive a statin if the patient argues that his LDLs are not very high, and why should he take a statin? So those are some important tools, like a stress test, and after an echocardiogram, and it could be stress treadmill stress test, it could be stress thallium, or it could be even a coronary calcium score, and if the calcium scores are high, even a CT coronary angiogram. So those are the diagnostic tools of coronary artery disease, which could be asymptomatic otherwise, because the patient doesn't have too much of symptoms. So these are tests which are important and now available, and up to calcium scores, they are not very costly. Yes, of course, a CT angiogram is a costly affair. Is about 2,000 rupees, and those are the tests that do say that the patient suffered from coronary artery disease or no coronary artery disease. And if the patients are at a high risk of heart failure, because heart failure per se, irrespective of them developing a coronary artery disease or no coronary artery disease, they are at a risk of developing heart failure, because hypertension, obesity, diabetes, they have a common soil. And if you see the staging of heart failure, stage A is patient who are at risk of heart failure. So who are this patient? Diabetic, hypertension, obese, that they are in their future could be a candidate for high risk of heart failure. And stage B, as I said, that subtle changes on ECG and echocardiogram, and patient never symptomatic in past, not symptomatic today, are stage B hypertension. And if you don't tackle them right then and there, then they would proceed to stage C, which is a frank heart failure per se, and they have symptoms of heart failure in past or maybe today. And once they are not controlled in stage C, then they proceed to stage D, which is end stage heart failure. So this is how you need to diagnose them and treat them early and treat them hard, so that they can be prevented in going into or delayed into going into heart failure per se. So these are few tests. So what do you think is the problem with us about the adherence to treatment in diabetes? What is your idea that what is the maximum, what is the most important reason that adherence to treatment is still not good in diabetes?
Yes, number one, the lack of awareness, the education, proper education is important for the disease. Sometimes we see many patients after achieving blood glucose level within the controlled range, they are discontinuing medicine. They are decreasing their own medicine himself or herself. And so education is most important, and it is very much challenging. This proper awareness, even in if they are well educated, well to do family from, they are also not knowing the disease properly. That is the most important channel I face. And another thing is issue is this cost of therapy. The cost of therapy is a burden for patient, especially the elderly patients. They have polypharmacy, so there is a huge burden of medicine cost. So I think it, and the medicine now after losing of patent of DB4 inhibitor and SGLT inhibitor, so this very good two molecule we are getting at a cheaper price, but still the GLP-1 another which is now also not
Costly.
available at a lower price. So it is still costly, and we cannot give those patients who require it. So this, I think this, and another is the adherence of patients. The patients are not adherent, and their follow-up is also infrequent. So these are the challenges, and also challenging those who are on multiple doses of insulin. So in that case, to maintain a strict glycemic range with along with avoiding hypoglycemia, that is also the challenges. And what is
So,
your opinion regarding correlation between diabetes and acute myocardial infection?
So I said that 11% of acute myocardial infarctions, they never knew that they were diabetic and they were diagnosed diabetes. Now, I think the age of diabetes is very important rather than the labels of diabetes. To me, the age is important. So if you diagnose diabetes and if you don't bring the HbA1c to below 7, there is a chance that a cardiovascular event, which could be myocardial infarction or could be a cardiovascular as a cerebrovascular. So those are very important. 70% chances that the patient would have a heart failure. So to me, diagnosing and the duration of diabetes is very important. And once diagnosed, in the first year, we need to hit hard and hit early, and that is why to bring down the HbA1c below 7 in the first year of their diagnosis. Otherwise, at 5 years, there's more than 50% to 70% chances that they would have a acute cardiovascular or cerebrovascular event, or would be a heart failure per se. So these are the reasons we need to hit them hard and hit them early and try to bring down the HbA1c within 7 of the first year of diagnosis. And that is where the fixed combinations are available with a lot of companies are important. So what, when according to you, you start a fixed dose combination, Dr. Subir, that what should be the HbA1c label that you look into and start a fixed dose combination rather than starting a monotherapy from very beginning?
Actually, nowadays, actually in our practice, the patients came usually in a late stage. So they are already on monotherapy. So maximum time we are bound to give dual therapy. But even in newly diagnosed patient, the Verify trial that shows that even if we use the early combination therapy, the results are much better. The glycemic durability is more. So usually if the patient have a HbA1c, even the Verify trial shows that HbA1c are between 7.5, 6.5 to 7.5 if they use combination therapy. So that shows the durability of the therapy. So very beginning we use usually combination therapy, but in selected patient, those are HbA1c less than 7.5, we can use monotherapy. If they with lifestyle monotherapy, they are controlled, so it is good. But nowadays our therapy targeted not only the glycemic control, but our approach is moving from glucocentric to cardio and metabolic centric. So depending upon the comorbidities, we have to select the therapy. So SGLT2 inhibitor and GLP-1 molecule, that these two group of drug had some extra glycemic benefit in terms of cardiac, renal, and metabolic. And even now in non-alcoholic steatohepatitis, they are also showing that benefits. So these drugs should be considered if there is definite indication or this type of comorbidity is present. And otherwise, if this is not present, but if we want to reduce the weight, if we avoid hypoglycemia, in that case also SGLT2 inhibitor and this DB4 inhibitor very much useful. And what is your opinion regarding the common comorbid condition in patients with hypertension?
So hypertension, diabetes, and obesity, these are in the serial with hierarchy. The hypertension patients, 60 to 70% would have diabetes, and they are mostly obese. And so that is how we feel. And once they have, as you said, that they have a common soil of origin, and once they have the higher risk enhancers, then the treatment of diabetes in those patients should be targeting medicines which have cardiorenal benefits, or at least friendly, rather than just starting with sulfonylureas or any small thing. So as you rightly said, like hypertension, where we now say that monotherapy are not the choice. You should straight away start with a fixed dose combination of at least two medications to start with, and if not controlled with it, we add a third medication, like in hypertension. Similarly, in diabetes, as you rightly said, that even we feel that even if it is 7.5, and if the patient is at a high risk of cardiorenal benefit, or is known to have atherosclerotic cardiovascular disease, I would start with a metformin and an SGLT2 inhibitor, even if it is 7.5 HbA1c. And of course, once it is not controlled, then I would add a DPP4, which sounds safer after the Carmelina trial with the linagliptin, which did show us that there were benefits. So we got some confidence in DPP4. Otherwise, still DPP4 carries a black box warning that they can increase heart failure incidences. Now, sitagliptin and linagliptin are the two DPP4 which are allowed to be used in patients known to have heart disease, heart failure as a class 2B indication. So that is our approach, and we start even as you rightly said, that even with the 7.5, try to start with SGLT2 inhibitor and metformin combination, and if the HbA1c is not controlled, add a DPP4, preferably sitagliptin and linagliptin. And right now we have a fixed dose combination of sitagliptin and metformin. About the PKPD of this, are they compatible as endocrinologists? What do you feel, that are they compatible in one pill, or are they not compatible? The PKPD of the sitagliptin, metformin, and the dapagliflozin combination.
Yes, this actually, when we are combining metformin, sitagliptin, and dapagliflozin in a single pill, so with this one pill, we can address almost 8 pathophysiological defects of ominous octet. So reducing the side effect, and simultaneously this will achieve a greater HbA1c reduction from the very beginning, and as well as some extra glycemic benefit already discussed. So the sitagliptin usually used in once daily dose, and dapagliflozin also used in once daily dose. So they are well matched in terms of PKPD profile. So only in case of when the GFR goes below 30, in that case metformin should be stopped. And when the GFR is between 45 to 30, stage 3B CKD, we reduce the dose of metformin up to 50% from the previous dose. And in case of dapagliflozin, that does not require any dose adjustment. We can initiate if the eGFR more than 20, and the current guideline is you can continue dapagliflozin till the renal replacement therapy start. And in case of sitagliptin, above 45 full dose and below between 45 to 30, the sitagliptin dose is 50 milligram, and below 30, the sitagliptin dose is 25. So this fixed dose combination with 50 sitagliptin plus DAPA10 can be used up to eGFR 30, and 100 sita plus DAPA10 can be used up to eGFR 45 or 50. And if the eGFR is below 30, So this combination cannot be used, as metformin is contraindicated and the sitagliptin dose is also reduced. So I think in that case you have to separately give the sitagliptin or dapagliflozin, or we can use linagliptin in place of sitagliptin when the EGFR is below 30. And what is your opinion on metabolic parameters in Indian patients, like lipid, BMI, etc.?
So as I was telling you that all diabetic should receive statin irrespective of their cholesterol level, and then you need to stage them that by using a simple calculator that how are at the risk of 10 years of any cardiovascular event, and accordingly bring down their LDL to the targets. If the patient is at a very low risk, we need to bring it down to 110 below 115, and if the patient is between moderate risk, we try to bring it down between 100, and if the patient is a high risk candidate, we try to bring it down below 70, and if the patient is known to have atherosclerotic cardiovascular disease, they automatically qualify as a very high risk patient, and we need to bring down the LDL to 55, and accordingly we start with a high intensity or moderate intensity therapy of statins. Now to start, if I to start a statin, I start with rosuvastatin because that achieves the target faster, and that has got a pleiotropic benefit that it reduces some part of triglyceride and also increases HDL, and has got an important role on CRP, which the atorvastatin trials has not shown, because the atorvastatin trials are only on the secondary prevention trial. But the right now we have good trials of secondary prevention even with rosuvastatin. So if you had not started the statin, the choice becomes rosuvastatin. But if the patient is taking atorvastatin and is on goal, then I would just continue with the statin. But that's important. That's one important factor. Now, as you said, lifestyle modification is important to bring down the BMI, and we have known that with a 10% reduction in weight, you could put diabetes in remission, and if you could reduce the weight by 15% or more, there could be reversal of diabetes. Am I right?
Yes,
If we use or not?
definitely, yes.
So that's
So
there comes
weight
the
reduction have
GLP-1 receptor
much
agonist.
benefit,
Yeah. So
reversal of
yeah, so
diabetes.
there comes the role of GLP-1 receptor agonist, and that is where the money is today, that costly medicine, because most of the Indian diabetes qualify for GLP-1 receptor agonist. And then other medication is a maximum tolerated dose of ACE or AB should be given to protect their kidney. Those are important criteria. Late known phenomenon in patients with preserved ejection fraction diabetes with some form of albuminuria, which could be above 30. So any form of albuminuria above 30 and potassium below 4.5 can be initiated, 4.8 can be initiated on findrinon 10 or 20 milligram accordingly to prevent them in going in heart failure or any cardiovascular event, and even their progression of the renal function halts or delays with fluorouracil. So these are some important medications which I think to us is important. Once we see a diabetic, statin, of course, on the list, irrespective of the blood pressure, try to put an ARBs on the board. And if the patient is having microalbuminuria above, could even mild above 30, that try to introduce, afford, because that's the tablets. So these are my choices. And as far as anti-diabetic, as we discussed, that if the patient is having diabetes and other risk factors, SGLT2 should be on board unless until contraindicated. And to me, the contraindication right now is GFR. To start a GFR of below 5 up to 30, we can start SGLT2 inhibitor. So that is important. And even in who are at a high risk, that they are metformin, that we can start SGLT2 before metformin, and metformin can be added once his targets are not achieved. And then if the targets are not achieved further, then we add a DPP4. So these are the choices. DPP4 still remains third on the list to us, say fourth on the list to us. Before that is metformin, GLP-1 receptor agonist, SGLT2 inhibitor, and then come the DPP4. as a cardiologist. I know to endocrinologists it's become the initial line of treatment, but to us this is where we put the DPP-4. I agree that although this 3-drug combination only has been tried with the once the SGLT2 dapagliflozin went off patent generic, and similarly sitagliptin become off patent and generic. We did not have too much of data internationally with the innovators about this combination, but we have real world data now about this the combination of either a sita-dapa or a sita-dapa metformin. We have only real world data from, and I found it's quite a logic combination to me. Of course, if GFR is a concern and if renal parameters are concerned, linagliptin and the Jardiance or the empagliflozin combination, which is the best of the class, but because there are no drugs need to be modified, the doses need to be modified. The first dose and the final dose are same. For linagliptin, you don't need to modify the doses. For empagliflozin, you need to modify doses. You can start with 10 and 5 combination. But with, as you rightly said, that with sita, metformin and DAPA, the only reasons are the GFR, which need to be seen properly and need to modify the doses from time to time if the GFR is falling. So these are my takes on the comorbidities and the management of comorbidities in diabetes.
And one thing I want to know, suppose a patient have the LDL cholesterol at below target level, and this diabetes patient does not have any other comorbidities like hypertension or any other comorbidities, the very low cardiac risk, and if the LDL is below 70, in that case even you prefer to use statin.
Above the age of 50, if the patient is above the age of 50, I would give some maybe moderate intensity statin, say 10 milligram of what you have described, a patient 10 milligram. But yes, I would suggest that the patient should be on statin, even
yes,
if he is below.
ADA also
The
recommended
newer guidelines
age of
also,
40, irrespective of cholesterol status, we have to use statin to prevent cardiovascular body. So
that is 40 by the Indian Diabetic
40,
Association. That is
American Diabetes Association guideline is 40. Age above
for
40.
Above 40, if the patient is diabetic above 40, even whatever is the status of his cholesterol, he should be on statins, yes. Right? So any other questions from your side? Because I have been I thoroughly enjoyed your discussions, and I got a lot of insights about diabetes and clinical inertia, as we always find, is a problem. And as you rightly said, that patient doesn't come for follow-up in time. Polypharmacy is a big issue because they are on statins, antihypertensives, and other medications, and of course the test and the medications itself are very costly, but still it is important to be time in range so that you can prevent complications of diabetes. Otherwise, ultimately, if you calculate the indirect cost would increase too much. And the fixed dose combination, as we have with Alchem in the form of Sita, DAPA, and metformin combinations, Dapanom M is and Dapanom M as that's with sitagliptin. These are important combinations which will bring down the cost for the patients. That is what is my take from today.
Yes, definitely. With combining these medicines, we are also avoiding the pill burden. The patients are already loaded with so many antihypertensive, statin, and so we are reducing the pill burden. So indirectly, the adherence will increase. And also simultaneously with this combination, actually, we are avoiding clinical inertia from the physician aspect, that we are avoiding the clinical inertia. We are targeting the agency from the very beginning, or very hard from the very beginning. So, and also the inertia from the patient size, they are also reluctant to increase their dose or regular follow-up. So in that case, I think combination is a very good choice, even if the patient does not come for follow-up. So it will more or less give some amount of control for some duration. So that's at the benefit of combining fixed dose in fixed dose combination. Also, the price is also becoming less if you consider the individual cost of medicine. So in fixed dose combination, the price is also reduced. And in some studies that also shows if we combine SGLT2 inhibitor with DPP4 inhibitor, so there is reduced chances of urinary tract infection. So that is also seen in some studies. Actually, with combining these two molecules, they are better glycemic control. That may be reason, and some hypothesis is proposed that DPP4 inhibitor may inhibit some DPP4 enzyme in bacteria or fungus also. So that may also be reason. But the most important reason for me is good glycemic control with this SGLT2 inhibitor and DPP4 inhibitor that will give relief from UTI or less chances of UTI with simultaneous use of this molecule. So this combination is very good, and nowadays is usually preferred after metformin, and even if there is comorbidity or definite indication, we can directly go for SGLT2 inhibitor, as you rightly said.
So very important, the mycotic genital infections can be less. The meta-analysis has been shown that once you combine a DPP4, and that could be both the mechanism that it inhibits the bacterial or the fungal growth, or at the same time the control of sugar is better with this combination. So both theory hold good, and that's an important point which you did touch into, and that's very, very important for the listeners that this combination holds good. And so even you can start with a combination of fixed dose combination of DPP4 acetagliptin along with dapagliflozin, and add a metformin at night also. That can be done, or we can combine which is now available. Mr. Ganesh, I think we are through the evening.
Actually,
are we allowed to take the questions from the house?
Yes.
If or if there are any, if you could read it out for us.
Yes.
Or you.
I was just waiting to finish up your discussion, sir. So it was a wonderful talk. Let me. There are actually a lot of questions, but I think the time is limited, so I'm just taking 2-3 of them. So two major questions are there. The one is for you, sir, Dr. Lhila. It's like how to differentiate between the heartburn and heart arrest.
Heart arrest is a different term altogether. Heartburn, or you can say that angina equivalent. So heartburn, angina could be manifested as a heartburn, and usually the heartburn, which is because of heart, is they are precipitated by some activity or following meals, whereas heartburn, which is because of the gastric issues, usually are not related to meal intake of meals, or neither they precipitated after some activity. So that is what is I could understand and I could answer. But heart arrest is a different altogether a different issue. But could be a symptom of angina. It could be angina equivalent, and that is mainly precipitated by some activity. Yes, at times MIs could be manifested as a heartburn, or could be upper GI discomfort, or vomiting and nausea, and we find that in Infeval, because of the increased vagal tones, the similar symptoms are there. And if you do an ECG, and so if the symptoms are there with heartburn and there is excessive sweating, and they're not going after some antacids or some for more than half an hour, it is safe to do an ECG, at least if the person is an adult above the age of 30. Is no morbidity, then of course it's worth to get at least an ECG that helps.
Okay. The another question is to Dr. Subir. Dr. Subir, can we reverse getting diabetes in pre-diabetes patient?
Definitely, pre-diabetes is a golden opportunity for patient, I say actually. At that stage, with intense lifestyle modification by reducing weight and with dietary modification, we can revert back to normoglycemia. And so if we can, it can prevent or also can delay the onset of diabetes also. So different studies shows even if we can lose up to 15% of weight, so that will reverse the diabetes. And patient have to strict throughout their life with diet and lifestyle. That is the most important factor. So in that case, the patient in the definitely in pre-diabetes stage, it is reversible.
Okay. Dr. Lhila, this question is, I think, for you. So, can ECG fail to identify the cardiac arrest?
Yeah, at times ECG may not be very helpful, but in that case, you need to combine them with some biomarkers like trophi and trophies, and if they are positive, then you become sure. And thirdly, if you can get an echocardiogram on board, which is slightly easier in India. Unfortunately, it is easier in India than in Western country. In Western country, you don't get a echo access at times, and in India, echo access is easier. So with an ECG, if you get a biomarker like a trophi or other cardiac biomarkers like CPKMB and echocardiogram, they help in diagnosing. And even if they are negative, then you still keep the patient if clinically you are doubting that it could be a cardiac related problem, that you do a serial ECG every half an hour and repeat the biomarkers after 3 hours. And if they are still negative, then only you can safely send the patient back home. Otherwise, keep them under observation, because they may not be able, they will not be seen on the first changes. So it could be a serial ECGs and serial biomarkers which could be required, or ECG along with biomarkers and echocardiogram could be required.
Thank you, sir. Dr. Subir, the last question is for you. Which one is better? Whether it's dapagliflozin plus sitagliptin or dapagliflozin, sitagliptin and metformin?
This is actually the patient's perspective. When the patient is already on metformin, many of the patients. So in that case, we have to choose this combination of dapagliflozin plus sitagliptin. And if the patient H1C is above, suppose 9% or 2%, 2.5% above the H1C target, in that case, we can use triple drug combination, metformin, dapagliflozin, and sitagliptin. But if the patient is already on metformin and H1C is around more than 1.5% above the H1C target, so in that case, we can use this dual combination of dapagliflozin and sitagliptin. And every composition like Sita and Dapa, Sita and metformin, the triple drug cannot be used when the eGFR goes below 30. So metformin is contraindicated. So there is no scope of using this combination below eGFR 30 plus. But the Dapa and Sita 50 with Dapa 10 can be used below 30 if initiated before the eGFR 30 or 20. Above, when the eGFR is above 20 or 30, can be initiated, and it can be continued up to initiation of renal replacement therapy like dialysis or renal transplantation. So both that actually depends upon the patient's status, glycemic and comorbidity status, that will decide which combination we will use.
Okay. Thank you so much, sir. Thank you so much, Dr. Subir Swar. Thank you so much, Dr. Sunil. Let me invite our Zonal Sales Manager, Mr. Sarup Chakrabarti, for a vote of thanks, sir.
Thank you so much, Ganesh. I think I'm audible. I am really, I was listening throughout the entire meeting, and I was going through a journey, strange journey. And it was a splendid interaction. I really owe my thanks to Dr. Lhila sir and as well as Subir sir from my core of my heart, that this discussion went to an extent which was a really state of art and worth spending time. It was a fantastic discussion. I really thank Dr. Lhila sir. I know that how busy you are, but still you have given your time for giving such an academic fiesta to make this program so successful. I am also really grateful for Dr. Subir sir. Sir, I know also you are a very busy endocrinologist, but still you have maintained the time and as well as given such a fantastic insight regarding this. I was seeing the prevalences, you touched upon the prevalences of cardiac and as well as diabetic and situations in India, why this combination therapy is required, what is the benefit of the other possible combination therapies, and pros and cons, as well as the price effectiveness. It was fantastically entire program was driven. I really thank that because of two joints in your the field of cardiology and diabetology met, so the dialogue became so successful. So thank you once again, sir. On behalf of Alkem, I owe my gratitude to all of you, to both of you, and all the members tonight who are listening this program. Uh, Thank you so much. This program was brought to you by Dapanom Duo, which is a very fantastic combination of Dapa-Sita, and both the combinations, as these joints already told, that were backed with good data and as well as studies, international studies like TCOS and this Declare Timi and DAPA the studies. So this combination is going to obviously help a patient a lot, both not only in terms of the efficacy and the lack of pill burden, but also in terms of the bill burden also. So thank you so much. Wish you a very good night. And once again, please give us this opportunity to make this kind of stage this kind of scientific fiesta in the near futures. Thank you so much, Lhila sir. Thank you so much, Swar sir.
Thank you.
Thank you, sir, and have a good night.
Thank you.
Thank you.
Sir,
Thank you,
thank you.
Dr. Lhila, and
Thank
thank you all the delegates, and thank you, Alkem, for organizing this such a beautiful program. Thank you.
Really.
Thank you so much.
Sir,
Fantastic.
thank you so much, sir. On behalf of Alkem Metanax division, we are really thankful. Both the clinician, you are doing in day-to-day practice, you are facing a lot of challenges, and that will be nicely presented in front of our podcast today. In future, we wish in future we also organize the physical program also. It is helping us to establish our brand. Thank you so much once again, and good night, sir.
And off the record, I must tell, sir, I have attended at least 30 to 40 podcasts throughout my entire zone, sir. And this podcast was become the best. It was so
Thank you.
elaboratively staged and so nicely driven. It already, I think Ganesh has stopped the recording, so I still this. I must confess this. This podcast was the best podcast we have done, and it was the best dialogue, in fact. The way you
Thank you.
both.
Thank you.
Thank you.
Thank you, sir.
Gone.
Thank you,
Thank you.
Sunil sir.
Thank
Thank you, Subir sir. Thank you so
Thank
much.
you.
Sir.
Thank you.
Thank you.
Thank you. Good night.
Wish you a very good
Good
night, sir. Pranam, sir.
Good night.